fractured as we embark on the timing and indications of surgical repair. When it comes to fracture repair, we also mend these broken fragments. Like broken pottery, we encounter the shattered and fractured facial skeleton. Oftentimes, it is not just the bony orbit, but is part and parcel of facial fractures, hence the term orbitofacial fracture. Orbitofacial fractures can be classified whether into simple or complex, depending on severity and extent of injury affecting parts of the facial skeleton. In a study conducted by our good colleague, Dr. Rian Parunan, in her fellowship year in NUH, evidence shows that indeed orbital fractures are incorporated in most of the complex facial fractures we encounter in ophthalmic trauma. Now, when it comes to orbital wall fractures, which are commonly encountered in facial traumas, more than 40% of all facial fractures, parts of the orbital rim and or bony orbit are involved. The very anatomy of the orbit itself makes it prone to these fractures. Now, the mechanism of injury would vary depending on the age groups. For children, could come from games or child play. For adults, could be coming from vehicular, industrial accidents, sports, or assault. For our elderly population or senior citizens, due to falls at home or elsewhere. So just to remember that the more severe the injury is, the more complex the fracture will be. Now, there are two theories proposed for the mechanism for the orbital floor component of orbitofacial fractures. So first, in the hydraulic theory, as intraorbital pressure increases dramatically and suddenly, the floor of the orbit blows out inferiorly at the point of its greatest weakness, just above the intraosseous course of the infraorbital neurovascular bundle. On the other hand, in the buckling theory, blunt trauma to the face, such as a punch to the cheek, transmits a pressure wave posteriorly, acutely compressing the bones of the orbit in the anterior posterior direction. This increase in bony pressure causes the weakest point in the orbit to buckle and crack, with the bone fragment thus created to be pushed inferiorly. But in real life, it is often a combination of these two. Where imaging, CT scan still remains as the gold standard in go-to imaging for detecting and defining orbitofacial fractures. Just we have to use imaging of the orbits in the entire face or facial CT with orbital cuts in fine cuts, around 1 to 1.5 millimeter cuts, as is recommended as concomitant facial fractures are commonly encountered. If and when available, IGS protocol or image guidance surgery protocol, which is finer around 0.6 millimeter cuts, is a huge or big help for surgical planning prior for navigation guidance surgery. Three-dimensional rendering or 3D reconstruction is recommended to optimize maxillofacial assessment. So for the residents, both coronal and sagittal views can be used to assess the orbital soft tissue and evaluate for fat herniation or ocular muscle entrapment. The sagittal view allows for assessment of the orbital floor and availability of the posterior ledge for implant support. The axial view, on the other hand, can help us delineate severity of involvement of the medial and lateral walls of the orbit. Highlighting the posterior ledge, which is a vital structure to visualize prior to placement of orbital floor implants. Visualization of the posterior ledge can be done intraoperatively in various ways, namely, one, through direct visualization during lifting of herniated orbital contents once you've seen the fracture site, if and when available, an operative endoscope and or a navigation guidance system. Orbital fractures, when unrepaired, can lead to a plethora of complications, whether soft tissue or bony changes. Blindness can herald from globe, optic nerve injury, or orbital compartment syndrome. In addition, aesthetically debilitating conditions such as clinically significant enophthalmos or globe displacement may appear with large bony defects. So like an artist working on canvas, he or she needs color to make art. For us surgeons, these are our so-called indications to intervene. So, for any significantly displaced rim, floor, medial wall, or combined floor and medial wall fracture with resulting into a clinically significant enophthalmos of more than 2 millimeter difference, persistent diplopia on primary gaze, entrapment of the inferior rectus muscle as evidenced in your clinical examination of ocular motility, A large floor fracture, even without the presence of entrapment or enophthalmos, wherein more than 50% of the orbital wall is involved, and of course, a presence of an oculocardiac reflex. Now, to introduce this new concept that I learned from my mentor, Dr. Gangadhara Sundar from Singapore has derived a system in classifying orbital-facial fractures using these patient-specific modifiers that would give a clear-cut fracture diagnosis to help streamline plans and necessary intervention. Each letter of the alphabet from A to I has its respective designation. Dr. Ganga has derived this system in order to have a thorough rundown of all the pertinent details regards to the injury, its extent, and severity. Using this system, however, is quite lengthy to write or present, but both the diagnosis and potential management can be clinched. Some of the alphabet designations are self-explanatory, such as your letter A and B, but allow me to shed some light to the other parameters. So C is for complexity. Orbital-facial fractures can be classified whether simple or complex, again, depending on the severity and extent of injury affecting parts of the facial skeleton. This slide would summarize all types of orbital-facial fracture complexity, with pan-facial fracture being the most complex with a broken facial skeleton all the way up to the mandible. D is for displacement, can either be mild, moderate, or severe. Based on the imaging of the injury, we determine the severity of the displacement and affected bones of the facial skeleton. Why? Because this would in turn give us an idea if there is a need to refer to other specialties for co-management of the case. E is for entrapment. For small, linear, simple fractures, especially in the pediatric population or young adults, these are the ones that we be most vigilant in anticipating possible entrapment of the inferior rectus muscle. Now, when you get your imaging results, some radiologists would commit for a possible entrapped inferior rectus based on the scan. But ultimately, we have to correlate it because it is more of a clinical examination finding when we check the ocular motility of the patient. F is for foreign body. So we examine the patient clinically and correlate or review the imaging for any presence of foreign bodies, whether they can be lodged in or on your ocular adnexal structures, intraocularly, or worse, intraorbitally. So now if we suspect any foreign bodies on imaging, the Hounsfield units will help us determine what it may be. So for anything more than 1,000, most likely it's not bone. G is for globe injury, which can be either closed or open, with definitions of the injury guided by the Birmingham Eye Trauma Terminology System, or BETS. The BETS was created by Kuhn et al. In 1996 to provide a simple, clear definition of all injury types and place the injuries within a comprehensive framework. The BETS also work hand in hand with the OTS, or the Ocular Trauma Score, also derived by Kuhn et al. H is for high risk or non-high risk. So patients who are high risk are the ones who have polytrauma with life-threatening injuries on massive blood thinners and those who are systemically unstable to undergo fracture repair. Now, I is for intervention. Is there any urgency to operate on that fracture? If you note a presence of an oculocardiac reflex, then the answer is yes. Timely surgery are reserved for the ones who can wait off. Late surgery is still an option depending on the overall health status of the patient, or if there is any concomitant active, open, or closed globe injury, wherein the fracture repair may aggravate that injury. Repair of orbital-facial fractures can be put off for the meantime until the globe is stable, and thus making it a staged procedure. However, it may have some intraoperative difficulty during the time of the fracture repair itself. So a lot of things must be discussed with our patients as to their expectations post-surgery. So always remember, the orbit lies in a gray area with a lot of neighboring structures that can also be damaged out of the domain of a regular ophthalmologist. We should never shy away asking help from the expertise of our colleagues. Building a good trauma team in an institution is beneficial in surgical management and ultimately optimal patient care. Multidisciplinary management with navigation guidance system for very complex orbital-facial fractures is ideally warranted as well. So the goals of orbital reconstruction in trauma are the following. We also have to take into consideration to restore quality of life and economic productivity. While small defects may heal solely by scar tissue formation, larger defects, especially those at risk of producing enophthalmos, diplopia, and hypoglobus, need an implant material of sufficient strength and optimal contour to support the orbital contents and restore the premorbid structural anatomy of the orbit. So implant of choice would depend on the age of the patient, size of the defect, and also the risk or likelihood of resulting into another possible fracture. Implants should be ideally inert and biocompatible, aiming to restore contour, function, and for integration with the bony orbit. There are several implant materials used in orbital reconstruction based on various characteristics. Orbital implants may thus be classified into from its source, whether it's autologous, allogenic, alloplastic, based on material, can be permanent or bioresorbable, based on porosity, which is you can be having a titanium implant or a porous titanium implant or a porous polyethylene implant or non-porous ones, and based on the type, whether stock implant, modified stock implant, or a customized PSI, or what we call a patient-specific implant, which is probably the most up-to-date type of implant at present. For surgical repair, time is gold. So the younger the patient, the earlier the planned intervention. Immediate surgery is required for trapdoor fractures that cause a severe oculocardiac reflex, which mostly occurs in children, but can also happen in young adults. Although no established consensus, traditionally delayed surgical repair for non-urgent orbital-facial fractures are placed within 2 weeks after the trauma. It is proposed in order to give ample time for proper ophthalmic and globe position evaluation and for most of the edema to subside. However, if surgery is further delayed, adhesion and fibrotic scarring around soft tissues may contribute to technical challenges in delayed treatment and may impede the recovery of ocular motility and visual function. Currently, indications of repair and appropriate duration between trauma and surgical intervention still remain controversial, but multiple studies show that early and timely intervention is essential and key, resulting into better patient outcomes. Jazayeri et al. Posited that early surgery might even yield improved outcomes because of the reduced scarring and fibrosis. So we will now showcase different orbital-facial fracture scenarios and their respective outcomes while applying what we learned from the NUH orbital-facial fracture classification system. We should now start off with a surgical video on repair of combined orbital floor and medial wall fractures. So the acronym that I've shown on the video, the AIOS, stands for the angle of inferomedial orbital strut, which is measured in the contralateral non-fractured orbit in order to more or less get a symmetric shape guide for the titanium implant to be placed on the fractured or in the fractured orbit. Using the angle measurements, the junction of the medial wing and floor of the prefabricated titanium implant were bent using a goniometer. Intraoperatively according to the 3 points along the inferomedial junction of the implant, which corresponded to the inferomedial orbital strut. of the orbital floor and medial wall junction, which would be your thick bone right here where the angles are. Okay, so now applying what we learned from the fracture classification system, we have the same gentleman from the surgical video who had a geriatric combined orbital floor and medial wall fracture of the left, which was complex, severely displaced with entrapment, no foreign body, no globe injury in a non-high-risk patient, wherein timely surgery was done. As seen in the post-op imaging, the AIOS bent implant achieves near symmetric results as compared to the contralateral orbit. This patient was able to recover very well and was able to go back to work without any problems. Next is a pediatric unilateral left trapdoor floor fracture, which was simple with mild displacement with entrapment, no foreign body, no globe injury in a non-high-risk patient wherein immediate surgery was done. This was a 10-year-old girl who injured her left orbit while doing gymnastics. She presented in the clinics with limitation of upgaze of the left eye, and in fact, clinical examination thus confirmed entrapment of the left inferior rectus muscle. Hand in hand with the imaging, CT scan revealed a left orbital floor trapdoor fracture. The parents of the patient were advised for surgical repair and have consented. Immediate surgery was done. The child was able to recover very well and was able to go back to school the soonest possible time. So this video shows motility 6 weeks on post-surgery recovery. No complaints of double vision, gaze, and only very minimal limitation on upgaze. This one is an adult unilateral right floor blowout fracture, which was complex, severely displaced with entrapment, no foreign body, no globe injury in a non-high-risk patient wherein surgery was delayed. This 47-year-old lady was advised to undergo fracture repair, however, had delayed her surgery as she was still undecided at that point in time. The operation was done 31 days post-trauma. We did encounter intraoperative difficulty due to the fibrosis of the orbital tissues, and unfortunately, even the infraorbital neurovascular bundle was obstructing the plane of dissection and had to be cauterized and cut intraoperatively in order to clear the plane for the placement of the titanium implant. Although early on post the recovery is an example that delayed surgery may lead to fibrosis of orbital tissues and greatly affect motility and rate of recovery post-op in general. This one is a geriatric unilateral left cranio-orbitofacial fracture, which was complex, severely displaced, with no entrapment, no foreign body, no globe injury in a non-high-risk patient, wherein the patient declined surgery. The 65-year-old gentleman had a severely displaced facial fracture, however, has declined surgery. Due to the multiple complex and large bony defects of the facial skeleton, he now has a clinically significant enophthalmos and facial deformity on the affected side. And the sad part is the diplopia or double vision is giving him difficulty in navigating, hence contributing to poor quality of life. And finally, to wrap things up, it is time for our pearl of the orbit. So for our pearl of the orbit today, for diagnosing and managing orbitofacial fractures, it would all start with good history taking, eliciting the mechanism of trauma, hand in hand with your thorough clinical and ophthalmologic examination to assess severity and extent of injury and making a complete fracture diagnosis, leading to a ample plan of intervention. Working with superb photo and video documentation with patient consent pre and post-operatively. For imaging, CT scan of the orbits and face in fine cuts, which is around 1 to 1.5 millimeters to catch the concomitant facial fractures. IGS protocol or 3D reconstruction, if and when available, can also be utilized. Timing is of the essence, especially if a patient presents with signs of urgency, such as an oculocardiac reflex. Timely intervention avoids or lessens intra and post-operative complications. Time is gold. The earlier we help these patients, the faster they get back to their normal lives to work and provide for their families. My references, acknowledgement, special thanks to Dr. Boyd Mangubat, Pisobers members, and MMC ophthalmology staff and residents for inviting me to share my talk. And before I end my talk, I would just like to impart some words wisdom to our dear residents in training. So if you find yourself struggling, always remember, like cracked, fragmented, and shattered bones of orbital-facial fractures and the struggle in ophthalmology, residency training, and doing your eye surgeries, life too is full of struggles. But these struggles will definitely become your story. And that's the beauty of kintsugi. Your cracks can become the most beautiful part of you. And then one last, just to plug in, shameless plug of an upcoming event from our society. So first, so thank you again, Makati Medical Center, Department of Ophthalmology, for inviting me to speak in your staff conference. It is truly an honor and humbling experience to share my talk in your prestigious institution. A pleasant day to everyone.
Thank you very much, Alex. Very impressive and very nice lecture that you gave to our department.
Thank you, po.
And also thank you for plugging in our fundraising for the golf. Sabi ng mga residente dito, they'll be practicing na for October 10. Meron daw tayong time. Okay, so we'll form a team here. Okay. Anyway, okay.
Thank you,
So
po,
I'd like to emphasize the fact in orbital fracture, a good assessment, a good history, a good CT scan will be a gold standard. Before, when I CT scan, we rely on this radiology, which it's obsolete now, and also we rely on early treatment of fractures, no. And that I would like to emphasize with our residents and also to the other staff of our department. So if there are any questions from the department for Dr. Alex. Wait, we have a question here from Dr. Oli. He's interested in going to oculoplasty, Alex. Yeah.
Hi, Doc. Thank you for your
Hi,
lecture.
good afternoon.
Doc, out of curiosity lang, kasi we know that the orbit of children are still partly developing. Granting that you have shown fractures that you've repaired at around 10, and most of the fractures occur in children at around 7 years old. Do you account, Doc, for the growth whenever you're placing implants also?
So basically, again, what I've said in my lecture, the choice of implant would depend on the age of the patient. So if I were to be given a pediatric fracture, I would shy away from using a titanium implant kasi unang-una masyadong malaki, masyadong rigid. Plus, the orbit is small. If you use a large titanium implant, you can hit some structures going to the orbital apex kasi masikip pababa eh. Kasi the orbit is a quadrilateral pear-shaped structure. So for pediatric fractures, mostly very, very uncommon for them to have like complex facial fractures compared to adults. Tapos, ang mga fractures nila mostly is linear and they're very pliable bones. So once the fracture breaks, the bone snaps faster compared to the orbit springing back to its normal location, kaya nagkakaroon ng entrapment. Ngayon, for small fractures, I would use probably a non-porous implant, usually osteomesh, pwede na, a mesh implant, just enough to put on top of that crevice or crack ng bone for the orbit not to get stuck there. Once you've released that entrapment and then you put in that implant, in time run 6 months to 1 year, magba-bio-integrate naman yun eh. So mag-heal naman siya with the tissue, with the bone itself. And you're right, lalaki nga talaga yung orbit ng bata. So that's a safest move you can do.
Thank you, Doc.
Thank you.
Okay, thank you for that question, Oli. Any more questions from the members of the department? Are they Sherman here? You have a question, Sherm?
Yeah,
Go ahead.
Alex, I just wanted to ask, this is
Yes,
so
Dr.
far
Valero.
removed from my specialty, no? But I'm just curious, how big an implant can you go for floor fractures? May limit ba yung size ng implant na pwede mong ilagay? Kasi halimbawa,
Yes, Doc.
what's the usual size of the floor fracture ba na nakikita nyo?
Okay, so for sizing floor fractures or orbitofacial fractures in general, number one is your imaging talaga. So if you have fine cuts, you have more or less more accurate way of measuring these defects. However, intraoperatively, the more complex the fractures, the more bones that are broken, the more the orbit is fully or well expanded, intraoperatively lumalaki po yung defects eh. So if you dig in, if you move other bone fragments, lalaki yung defect. So intraoperatively, ideally, parang sa cataract for IOLs, you are prepared with PCIOL, meron kang sulcus, meron kang ACIOL, anticipating complications. So ideally, you measure the defect, especially from the sagittal cut ng CT scan, in order to see more or less gaano kahaba yung fracture. Age would also be a factor. Race and gender would also be a factor kasi may mga race or genders na shallow or straight yung orbital walls like East Asian patients. Ngayon, yung sa fracture size, for the implant size, the newest ones that have been on the market are your prefabricated titanium implants. They come in 3 colors. So mayroong blue, may violet, and then may gold. So usually they're small, medium, and large. So ideally, if you have an idea already, an inkling kung gaano kalaki yung fracture, you have everything prepared. And sometimes you have to prepare your implant cutter and your file. Kasi minsan, kahit yung medium size implant, pagpasok dun sa orbit, masyado pa rin masikip, you have to reduce the implant and then file the sharp edges after cutting it.
Okay. Are there tawag dito, occasions where you're not able to cover the entire defect and you'll have to go with a smaller implant, or you just have to protect some tissues over others pag masyadong malaki yung defect niya, yung fracture niya?
Yes po. Usually kapag, especially for complex
Yeah.
facial fractures, so the dictum of repair would be from top to bottom and then from out to in. So basically, last nagagawa ang ophthalmic tsaka orbital surgeon. Kasi ang domain natin as eye doctors and orbital surgeon would be your floor and your medial wall. So kapag naayos mo na yon, most likely kung yung measurement mo is slightly a little off, malaki, kapag na-reduce na yung, sabihin natin, let's say a fracture on the lateral orbital wall, which is zygomatic bone, ZMC fracture, pag na-reduce yon, pwedeng lumiit yung defect eh. So that would in turn help your intraoperative decision making.
Okay. All right. Thank you very much. Thank you.
Thank you pa.
Yes. Kaya. One of our residents have a question here. Kaya. Yeah.
Hi, hello po, Doc. Thank you for the
Hi, good
lecture.
afternoon.
Actually, Doc, yung question ko is, have you have any experience with 3D printing implants for
Yes.
floor fracture repair? And
Yes.
what do you think about it, kaya, Doc?
So the technology for 3D printing implants is what we now call PSI or patient-specific implants. So it can be done in various ways. The easiest way is to have the DICOM ng CT scan be given to a 3D printing company, and then they have a software to analyze the orbital volume of the contralateral orbit. The DICOM images are then computed and then mirrored for the fractured orbit. So more or less, they can estimate the exact volume of the non-fractured orbit. So for when it comes to reconstruction, you use it as a guide. So one way is to print that STL and use that in the operating theater. You sterilize it, and then if you have any thermolabile implant, or your osteomesh or your titanium implant, pwede mong i-contour doon sa 3D printed orbit. Yun yung isang pinakamadaling gawin. Another is, if your patient has budget, usually they send it overseas. Yung from Singapore, they send it overseas to the US or Germany to have that DICOM data analyzed and then print the implant itself. So yun yung talagang saktong implant dun sa fractured orbit mo. Ngayon, there are countries na I think hindi pa kasi FDA approved eh. Tama ba, Dr. Boyet? Hindi pa kasi lahat nag-FDA approved nung implant material for the 3D print eh.
Yeah. Yeah. Correct. Yeah.
So it's very promising. It's a new new frontier for repair of orbitofacial fractures.
So, Doc, the utility of it is for planning, but as of now, not really for the implant itself.
Come
Or
again, your question is?
more on for planning of the surgery with the mesh, but not really for making the implant itself for now, though. I
No,
think
other
yung
other other institutions overseas can use that DICOM image and then make that data para gamitin nila for producing the implant size and the contour. Kasi the problem is with the old titanium mesh implants na you have to fold it by yourself, you have to mold it by yourself, hindi mo nakukuha yung posteromedial bulge, yung junction ng floor tsaka medial wall ng orbit. Kaya in turn, kahit alam mo that you've adequately and properly placed yung floor and medial wall, medial wing implant na ikaw lang ang nagtupi, minsan may inophthalmos pa din yung patient. Minsan hindi pa din pantay yung itsura ng orbit, minsan may hypoglobus pa din. Kasi very, very important yung thick bone na yun, yung angle na yun, that bulge, which is being simulated nung prefabricated titanium implant.
thank you so much, Doc.
Well, that's good. That we have that three. It actually acts as a mold for your implants to be contoured during surgery or even pre-surgery. We can order. Any more questions from the members of the department? Any questions from? If there are none, okay, I think there are no more questions. Anyway, there are no more questions here, Alex. So thank you very much for that very, very interesting and very informative lecture that you have.
Thank
And
you
we
po.
look forward for further lectures to us. Okay, Alex. Thank you very
Sige po.
much. Okay, see you in the golfing. Golf this October 10. Thank you.
Opo. Thank you po. Thank you po. Thank you
Thank
po.
you again,
Thank you,
Alex.
Alex.
Thank you po,
Thank
MMC. Thank you
you.
po, Dr. Boy. Thank you po.
Thank you. Okay, Sharon.
No
Yeah.
announcements naman, just say a little prayer for our residents who took the boards. The results will be out by tonight. By tomorrow. We'll be having our deliberations later, so we'll see. But that's it, no? So any announcements, Drem?
You want to announce, Doc, the new manager?
Yeah, andito na ba si Roxane? Wala yata siya dito. So we have a new unit manager in the eye center, no? Her name is Roxane, no? She replaced Yoko. She came from the parang Japanese relations office, no, in Makati Med. So she's our new unit manager. Right now, she's still working with Yoko to get herself familiarized with the eye center operations. So when you see her, say hi. No, she's very nice and she's very efficient. So let's all welcome her to the department. No, so any other announcements, Rem? Reminder lang, please, all consultants, your logbook signatures. Medyo bumababa yung ano natin, ha, yung ating completion rate. Just please make sure that you sign all your entries for the logbook. Okay. Thank you very much, everyone. Have a good weekend. We'll see you next week. Okay. Bye-bye.
Thank you very much.
Thanks, Dr. Boyet.
Thank you.